So the external urethral meatus is one of the most narrowest parts, rather is the narrowest part of the urethra. And that is something that we want to keep in mind. Now there are four parts of the male urethra. So if I draw this as the bladder, and pardon my drawing, this is your first part, that is the prostatic urethra. Then you have the membranous urethra. So prostatic urethra, the membranous urethra. Now it's called the membranous urethra because it actually passes through the membrane. All right, passes through the membrane that is nothing but the urogenital diaphragm. So the urogenital diaphragm. And as it passes through the urogenital diaphragm, it goes into a curve which is called as the bulbar urethra, which is the most prone to damage. And then you have the penile urethra in cases of the male, which is quite long compared to a female, right? A female is around 3 to 4 centimeter. The total length of the urethra would be around just the bulbar part, and 12 to 18 centimeters is of male, of a penile urethra. So this is the normal urethral anatomy. But when you go into the diseases that actually are occurring along with the urethra, so the first one that I really want to talk about is something called as an hypospadias. Okay, so I'm going to write it as HP whenever I mention it in further, but hypospadias is what we are talking about. What actually occurs in an hypospadias versus an epispadias. All right, so hypospadias is basically that the urethral opening is usually on the glands of the penis, right? But what happens out here is that if this is the dorsal part and this is the ventral part, all right, if this is the dorsal part, because obviously when you're looking at the anatomy of the human body, and let's say if this is the side view, this is the penis, so this is your dorsal part, this is your ventral part. Okay, so the hypospadias is a condition where the urethra actually opens on the ventral part. Okay, so it could be any part of the shaft of the penis. So now let me draw the ventral view of the penis, and this is the scrotum, this is the shaft of the penis, this is the glands. All right, again, pardon my drawing. So you could have a distal hypospadias, a mid-shaft hypospadias, or a proximal hypospadias. And as you go downwards, as you go more proximally, the severity of the disease increases proportionally. So the patient is usually coming and complaining of a simple thing. He says that the complaints are going to be that the urine is downward. He usually wets his thigh, downward urine. Second is that there is bending of the penis. Okay, so why is there bending of the penis? Because of the fact that when the openings are instead of being on the glands somewhere out here, if it's at this spot, or if it's at this spot, X is the epispadias. So, or this, what happens is that there are constrictions called chordae formed. Okay, so these chordaes are bending. They are causing the bending of the penis, and because of that there is also certain amount of infertility. All right, and more proximal the opening of the urethra, more is the bending of the penis. So the penis becomes something like this. Okay, as the lateral view, the penis becomes a bent penis. So that's hypospadias for us. So then how do you treat an hypospadias? All right, the treatment of an hypospadias, you want to begin it between 6 to 12 months of age, and you want to definitely do it before 12 months of age. Okay, and what we need to do is that we first need to do something called as an orthoplasty. So first you do an orthoplasty. Orthoplasty is that you remove these fibrosis and you make the penis as it is, the penis of the penis as it is. Then you do a urethroplasty, so that you make sure that the urethra does not open here, but actually opens at its anatomical site at the glans penis. So urethroplasty. Then you do a glanuloplasty. You do a glanuloplasty where you do reconstructions of the glands, because obviously if you're introducing your urethra into your glans penis, you need to do a glanuloplasty. And then you need to do a skin cover and a scrotoplasty. Skin cover and a scrotoplasty. Now the reason, and very important, is that you don't do a circumcision here, because you're going to use the frenulum. Okay, you're going to use the prepuce, you're going to use this foreskin as well, frenulum and prepuce, for reconstruction. Okay, so you're going to use it for reconstruction, so there's no point of doing a circumcision, correct? Okay, so this is the basic surgery. Just the names for the distal, mid shaft, and the proximal. Distal, you want to go for something called as a TIP, or a Mastardi, or a Matthew procedure. For a mid shaft, you want to go for a Snodgrass procedure. And for obviously the proximal, you want to go for a Dennis Brown repair. Very interesting, Dennis Brown repair. Or your Thiesh Duple. So I'll just give again the TIP, Mastardi, or the Mathi, Snodgrass, or Dennis Brown, and Thea Duple. So there's something called as a Dennis Brown syndrome as well that we'll see in RCC. Okay, quite interesting when it comes to, I think it's more or less associated with something of the Wilms tumor, more of Wilms tumor. It's associated with Wilms tumor. It's called the Dennis-Drash syndrome, where there's a lot of intersexuality, mental retardation, and GI abnormalities associated with Wilms syndrome. Along with, it's another condition that you can keep as a differential when you're talking about congenital Wilms, along with Wagner, Dennis-Drash, and Beckwith-Wiedemann syndrome, which is again Wilms omphalocele hemihypertrophy of one side and mental retardation. Something that's same between Dennis-Drash and Beckwith-Wiedemann is mental retardation, but definitely you can differentiate the two by using the intersexual or hermaphrodite nature of Dennis-Drash. Okay, that is very important. Next is epispodias. Epispodias is the exact opposite. Epispodias, as I said, as we spoke in that the epispodias is in the ventral region, the hypospodias is in the ventral region, the epispodias is in the dorsal region. It's usually associated with something called as an ectopic vesicae. I would love if you would Google this term, the images of these ectopic vesicae. Basically what occurs is that the bladder is actually open and it's not covered by your anterior abdominal wall, so your anterior abdominal wall is missing, and because of which your bladder can be seen, and your penis is underdeveloped, and the urethra opens on the dorsal side. Okay, and the testes are undescended. So it's a combination of exposed bladder, epispodias, spodias, and a very important undescended testes. And undescended testes, as we know, it can lead to intratubular germinal neoplasia, which will later go into seminoma. So that too. And it has a very important case of pubic diastasis. Basically the iliac bones are not fused, because of which the bladder remains exposed and the urethra is on the dorsal side of the penis. Then we have the prostate. We have something called as the posterior urethral valves. Very interesting, as it causes it's an important cause of hydronephros too, and usually a bilateral hydronephros as well. Okay, it's exclusively in males. So if you have a male patient, obviously you want to think of this. When there are recurrent hydronephros, and antibiotic cover is also given, and there are recurrent hydronephros, so you definitely want to go for your micturating cystourethrogram, or just your urethrogram. And when you do a urethrogram, you will definitely see that these valves are present near the urethral junctions, and what actually occurs is that there is blockage of urine flow. So because of which obviously there are three types. There are type 1, type 2, type 3. The type 1 is the most common type, and therefore which is causing actually hydronephros. So yes, posterior urethral valve is quite interesting. You can see a keyhole defect on your USG. It is a prenatal USG diagnosis can be done, and as I said here, MCU, that is a micturating cystourethrogram, also shows this keyhole defect. You just want to do a simple management. You want to do a Foley's catheter insertion. You want to decompress the system first. You want to do a Foley catheter and you want to decompress, and then later you can do your fulguration of valves, which is basically just breaking the valves with lasers. So basically what is occurring is that either ureter or or cysto-urethral junction, there shouldn't be a valve, but there is a valve here, and that's what's causing actually the issue. Okay, then we have something very interesting called as phimosis. And a lot of people these days are suffering from phimosis because of poor hygiene, first of all. What actually occurs is that there is inability to retract the foreskin. Okay, so actually your foreskin gets tightened at the end, at the glans. So there's ballooning of the foreskin. There is definitely UTI. There is balanostosis, titus. There is hydronephros as well. Very interesting case of hydronephros. This is a bilateral hydronephros again, because there's only one penis, so obviously bilateral hydronephros. Definitely you want to go for circumcision. You do a conventional circumcision, or you could do definitely a stapler circumcision. But this is very interesting is that circumcision can definitely also lead to hemorrhage, can lead to strictures, can lead to cordae, can lead to infection as well initially. All right, so this is phimosis. Incision is made dorsally. So what actually occurs in this is that first you make an incision, okay, and this is your prepuce area probably. You make an incision, you open it up as you open up a chocolate wrapper, and then you just cut the entire thing off, and you suture it out here. Okay, you suture it at the junction with the frenulum, and these are dissolvable sutures, proline sutures, can be used. Then we also have something called as a paraphimosis. Okay, paraphimosis is equally interesting and actually occurs while doing the Foley catheter incision, where you do not reposit the foreskin, and what happens is that the entire foreskin is constricting the penis. Okay, so it constricts the penis, and there is also edematous foreskin. Okay, so you don't really want to do a management. You want to do conservative. You want to apply glycerin, and then you want to apply lidocaine, and then you want to see if it actually goes back to its normal. But if that fails, obviously again you need to do a dorsal slit procedure. Not necessary that you do a circumcision, but you could do a dorsal slit procedure. Very interesting. So these are the few diseases that I wanted to cover. The rest are obviously very interesting, and we shall cover it later as well. Thank you.